Hello, everyone. Good evening. Wherever you are, where I am is evening. I think where Julian is evening as well. So, welcome to our first webinar of this series. First of all, just to thank everyone to be here. I'm just going to do a little bit of cleaning the house thing because we want to make sure that this meeting goes well for everyone. So I will ask everyone to keep the mics off and the cameras off throughout the whole meeting, throughout the whole webinar. It's being recorded as well. If you don't want to be on a recording meeting because your name is showing on the screen, please just remove yourself from the meeting. But at this point, it's already being recorded. I'm going to do a presentation and then we'll have a Q&A session. So we can have a Q&A session. Julian will talk a little bit about what we're doing here today and in the next couple of weeks. And that's pretty much it. At the end, we'll give you the option to talk and ask your questions. That's when you can unmute yourself and come to the stage. You can put your camera on and we can talk a little bit all together. So Julian, do you want to say anything to everyone? We have around 50 people almost here now. So go ahead. Nice to see you, by the way.
Of course, nice to see you. Nice to see you. You look in a great shape. It's a pleasure to be here with everyone. Thank you for coming. I know if maybe for someone like me today has been quite a long day at work, so well done for those of you that connected at present. And I think also this participation, the nature of this participation, I think also resonates on the fact that the topic is very fragmented. You know, like remote scanning now is the topic of the day, but now it's becoming like a reality every single day. You have that colleague and say, "Oh, have you heard? Apparently, we can do scan remotely." And so yeah, we're still thinking at times it will be a thing of the future. But as Sam, you always say, the future is now, and there are actually a lot of realities that are already implemented remote scanning. But I think we are here today to understand more with you, Sam, that you're an expert on this. Why remote scanning can be beneficial? What are the pros and cons of remote scanning? How can we implement this workflow? And especially what it is remote scanning and how it works. So we're gonna do this not only today with Sam, which is going to give us like a fantastic introduction about the topic, but also in the next Tuesdays across this month and May as well. So there will be a full series about remote scanning where you're going to learn what it is, and we're going to discuss all of the things we just mentioned in detail. So if you want to know more, I think would be nice for you to attend all the series. But first today we got here Sam, which I already seen the presentation, by the way, little spoiler, and will be amazing. So stay connected until the end because there will be few surprises as well. Sam, I will pass the stage to you.
Thank you so much, Julian. Just keep an eye on the waiting room. There's people still joining, so I won't be able to accept
Of
and
course, I'm gonna do that. I'm gonna do
Yeah,
that.
perfect. I will share my screen. Let me know if you can see it. Can you see it?
Yeah.
Yeah, okay. So I just need to move back to it because otherwise I won't. You still see it? No.
Yes.
Yeah, okay. I can see it. That's why I'm asking. Give me 1 second. I'll put it back on.
Yeah. Put it back on.
There you go. That's perfect.
There you go. There you go.
Okay. All right. So I'll start my presentation. So my name is Sam, as probably most of you are aware. If not, here I am. I'm the founder and CEO of Everything MRI, the company that I co-founded with Julian. And today I'm going to talk about remote operations. It's basically a passion of mine, and there's a lot of people trying to understand a little bit more about remote operations. So that's why we decided to do this webinar. I just have a quick disclaimer. I work also for Ionic Healthcare. So Ionic is a remote scanning company, tech company, and I'm the head of training and development for remote operations for them. So I just want to say today that everything that I say in this presentation is in my name and not in Ionic's name. So I'm representing myself and myself only, and not the company itself. So I'll jump straight into it. I'm going to show you this tiny video. It says conclusion there because it is what I want you to take from this presentation today. As you can see, there's an ant, and the ant can't get out of a circle that was drawn by a pen. I'm sure a lot of you have seen this video before, but the idea here is that most of the barriers in our lives are invisible, are in our minds, and it's up to us to deconstruct them and overcome that same barrier. So it's all in the mind, and I hope the idea that you bring from this presentation today is the limits only exist on your mind. So you can always do something more and something different. So what are exactly remote operations? That's what I'm going to try to explain to everyone here today with a little bit of examples here. It's a short video that I did while I was in France. People were scanning from Vienna, ECR, and I was in France with a pineapple. So most of you or some of you have seen this video, but what are remote operations? That's the main question. So most of you probably think it's just scanning from home. I have a picture here from my friend Anton. Kudos to him. This picture is just for illustration purposes. Of course, he wasn't actually scanning a patient, but everyone thinks remote operations are scanning from home. It is also scanning from home, but that's not only it, okay? So remote operations basically are a toolbox, okay? Imagine you have a toolbox and you have many tools inside of it. And one of the tools is monitoring. When we have our scanners, they're always monitoring what you're doing. They check your helium levels, your temperatures, how your gradients are performing. These kind of remote operations have been there for many, many years, almost since the inception of these scanners. So this is a tool that the OEMs, the manufacturers, have been using for a long time. All right, and then of course we have the support. So when you have troubleshooting, when you're stuck with a protocol, there's an error message on your scanner, you don't know what to do, they access remotely to support you. So most of you probably been through these two tools of our remote operations. Then we have the third one, and this one is a little bit newer, but it's still there, training and education. So we can train radiographers, we can educate them, we can help them with certain protocols. This also, most of you have been through this when you have an app specialist that just logs in remotely, tries to fix your protocol. You're doing a whole body MRI, the machine doesn't move properly. So they just logged in remotely and they try to educate you how to better sort that problem. And lastly is the scanning. So the scanning is the one that we all are talking about. As I said before, it's a toolbox. We have all of these tools, but the one that is stirring the waters is the scanning bit. And that's the one I'm going to focus today because it's the most important tool of our operations. So remote operations, of course, we have advantages, pitfalls, challenges, pushbacks, where all of those. So I'll start with some advantages and I'll go one by one through them. So one of the advantages is to help with the shortages, which most of the manufacturers will try to sell you this. It's a great tool for shortages of staff, but they forget that it's also a great tool for countries that have excess of staff. And I'll touch upon this a little bit later on. Then increase efficiency. This one is quite straightforward. Then we have skill set improvement, also an advantage. Increased safety. And I'm sure a lot of you are raising your eyebrows and like, what is he talking about, increased safety? But I'll touch this point quite intensively during the presentation. Then we have work flexibility, which for me as a radiographer is one of the biggest advantages of these operations. And then of course, cost savings, which is the main advantage point for a hospital or a clinic that is trying to implement operations like that. So let's start from the beginning, shortages and excess of staff. So I'll start with the shortages of staff. So what we can do is we can fast track staff training. So we can train people quicker. We can have an operation with multi-scans, multi-vendor radiographers. So for example, we have a radiographer, and I'll show you a video of this. There is scanning on a GE scanner, and at the same time is scanning on a Canon scanner. So they can do more scans at the same time within the same facility, and we can train people on those scanners quicker as well. We can centralize radiology expertise, so we can have experts within the same center doing remote scanning on areas that don't have the expert people available. For example, cardiac scan in the interior of Portugal, for example. We need someone that can do that scan, but we don't have that person, so we can centralize that radiology expertise. We can use other medical personnel to work as an MR safety technologist. I put an asterisk there because I'm going to mention this term later on, and I understand there's a little bit of conflict when I mention other medical personnel, because we want MRI safety trained people within the facility, and I will talk a lot about this too. And then, of course, we have extended hours, lunch breaks, staff meetings. So all of these things we can improve with the operation that is done remotely. For example, if you have a staff meeting every month and it takes 2 to 3 hours, you have a big department, you can just take all the people away and get those scans done anyways remotely. So we don't need to use remote operations as a full operation. We can use it in certain periods of the day or the week or the month, depending on your needs. One of the things that I like to say, and I will stress this out many times, is remote operations are not for everyone. Remote operations are for those people or for those hospitals that actually need it, okay? So keep that idea in mind. And then, of course, we have excess of staff. So I'm going to give you the example of my country and the example of Julian's country and my neighbor country, Spain. So Italy, Spain, Portugal are just a few examples. There are more where we have more staff than vacancies. So we need basically, sorry, someone drew a line on my slide. It's not part of the presentation. Julian, I don't know if you can remove it in the meantime. So we try to combat this excess of staff by providing people to actually scan without leaving their own country. I had to immigrate to London because there were no jobs available. So basically I had to leave my country. I left everything behind. And with remote scanning, we can try to avoid that. We can have people not leaving their country and still do the job they love. Then, of course, we can optimize workforces and expand the MRI services to remote areas as well. So increased efficiency, second point of my presentation. In terms of increased efficiency, it's mainly for the hospitals and for the managing teams, okay? So hospitals can optimize their MRI scheduling, so we can schedule more appointments within different periods of time. For example, we can work from 6 a.m. to 8 a.m., those dead moments, or from 5 p.m. to midnight. It's really, really manageable with the hospitals, and it's you can change it anytime you want. Scanners that are closed can now be open. Canal normally says that the most expensive scanner in the world is the one that is not working. So there's another way of increasing their efficiency. We have an example here in Portugal. My father, unfortunately, had a health problem and he needed to have a scan, and the hospital there he went, which is massive hospital, didn't manage to do an MRI scan for him because the scanner was closed due to lack of maintenance and stuff. With remote operations, my father could have had that MRI scanner. We can reduce waiting times at least, operate machines around the clock, 24/7, reducing the backlogs from COVID-19. And experienced radiographers can log in from anywhere and do complex examination, as I mentioned before. Then, of course, we have a skill set improvement. Some of these points will kind of interlock each other, and you will understand what I mean by that. So when I say skill set improvement, sorry, I'm going to do just a short stop here. I don't know who's drawing on the slides, but there's already 2 of them. So I'm going to stop the presentation here, and I'm going to restart. I'm really sorry for that. Okay, perfect. Sorry, guys. I will put the presentation again on for everyone else. Okay, really sorry for that. Right, so where was I? So remote training, real-time while scanning. So one of the things that increases the skill set or improves the skill set is also the fact that we can basically train someone while they're scanning. So imagine you're doing a prostate scan, you've never done it before, you don't have anyone next to you that can help you. You can just have someone accessing your scanner remotely and he will guide you through it. I'm one of those people that learns way better with hands-on. So while I'm doing it, I can learn way better than if I'm reading a book or watching a video. So if I'm actually sitting on the scanner and I have someone teaching me, click here, now plan there, angulate on this, increase your FOV, reduce your TR, while I'm actually doing a patient, I think that helps a lot in terms of a skill set improvement as well. So increased safety. I'll give you one slide here, and I promise I'll talk way more about it later on the presentation. But for now, I know a lot of you are raising your eyebrows and thinking, what is this guy saying? How can we increase safety with remote operations? But I'll try to show you how. So in my opinion, we can do extra screening, all right? again, this is not for everyone. It's for those sites that need it, and I will explain this. So for example, let's say you're having a patient coming to you, you have one radiographer there, one sitting at the scanner. That radiographer will do the safety questionnaire, bring the patient in the room, position the patient, get out, right? What I'm proposing with remote scanning, what we are proposing in terms of community of remote scanning supporters and aficionados, is the fact that not only that person that does the screening and brings the patient in does the safety screening, but the remote operator at home can also do that safety screening. So we'll have two people. I know some people will tell me that we already do that with two people on site doing it. That's not the point. The point is we can actually do two screenings while having just one person there. Then, of course, we have new technology being developed like VR, AR, holograms that will eventually permeate this technology, this market, and help us be in the room while not in the room. So I'll show you an example of an hologram consultation that happened in UK. And this is something that we can actually implement within remote scanning and have the remote operator talking to the patient as an holographic entity inside the room. Then we have stuff that just focus on safety. Nowadays, radiographers are multitaskers. We do a little bit of everything at the same time. And I'll show you a graph on this. But eventually in the future, we'll have dedicated safety technologists, as I mentioned before, the MRI safety technologists, and we'll have dedicated safety training, which is a point that I like to focus on my safety talks as well. Because at university level, unfortunately, this training is not happening at the standards that we wish it was. So my favorite point of remote scanning, work flexibility. So managers can assess the staff strengths. For example, I love to deal with people. Probably my manager can put me working with patients more, or I actually don't like patients, so I want to work from home. So you go home. So the management team has this flexibility to work with the preferences of their own staff. Then, of course, pregnant members of staff, they can work a little bit longer and have that pay cut a little bit later, because we all know when we go to paternity or maternity leave, our salaries get cut quite a lot. So if you can prolong the time that you're still working before you do your maternity or paternity leave, you'll get a less pay cut. So you have that flexibility as well. And then, of course, you have neurodiversity, autism. We have members of staff that, due to any unforeseeable circumstances, became unable to perform their normal duties. For example, if you break a leg, you can't go to work. So all of this allows you to work while not at site. So there's a few things that we like to point out in terms of work flexibility, but these points for me are very close to home, and I think it's important to mention them. Lastly is the cost savings as an advantages. So for cost savings, of course, hospitals can reduce the need for big teams. So during non-standard hours, of course. So let's say from 5 to 8 or 5 to 10, normally we scan alone. If we are in a hospital that has a resus team somewhere, or we will have to close the department because we don't have staff there. So we can start basically staffing those areas with cheaper labor, let's put it that way. And then, of course, we have highly skilled staff. Let's say in UK, we have bank, agency, bureau, ad hoc hours. All of those hours are paid extremely well and way higher than a normal radiographer that works a full time. So we can start, and when I say reduce these roles, the hours these roles do, is not, I'm not saying that we're raising them. We're changing the way they work. So instead of them going to the hospital, they can do it from home. And instead of getting paid, let's say £60 an hour, they will get 55 or they will get 50. Still way above the normal rates, but they will be doing it from home instead of actually coming to the hospital. So there's a lot of cost savings advantages for both sides of the game, not only for the hospitals, but also for the radiographers as well. They can save in commutes and in money that they have to waste ordering a dinner to their hospital or just taking a bus or a train or whatever. And of course, the number of scanners that are closed without anyone, as I mentioned before, will decrease, and we can train more effectively and less costly. That's also very important because we don't need to close a department to send 5 radiographers to do a course. Let's say we need a cardiac course. Instead of sending all of them away, they can still work from home, for example, and do everything MRI online cardiac course. So they can do both things at the same time. So cost savings, everyone wins. This is a short example of a command center, as we call it. This is a courtesy of Ionic Health. They gave me this picture so I could use it. And as you can see, there's people working in different machines. At the top, you have a big screen where the supervisor of the center can see every single scanner to see what's going on with every single one of the patients in those centers. All these pictures, all these images are being taken from different centers, not only the same, and you can be doing a CT and an MRI at the same time, or a PET MRI or PET CT. So, as I said before, we also have challenges, of course. One of the challenges, I'm going to name them all here as well. Not all of them, but the ones I believe are the most important so far. So lack of regulation. So lack of regulation is a big point for remote operations challenges at the moment, mainly for adoption. But I'll touch upon that later on. Communication, big one. Remote operations can't and will not work without effective, clear communication. Then we have staff acceptance. This is also a big point. We have people that love the idea, we have people that hate it, we have people that have no idea what it is. So it's really important. The staff acceptance is a challenge for the implementation of remote operations. This one, I actually had an important conversation about this today, which is the lack of information and misinformation that is out there by bad players in the game that actually bring down the remote scanning adoption instead of promoting it. Then we have, of course, IT support and cybersecurity challenges and concurrent scans. This is also a big point of discussion. So let's start with lack of regulation. This is, I believe, the biggest challenge in adopting this technology, because people come to me and say, well, I would love to do this. Is it legal? Is it possible? Is it not possible? Is there legislation? It isn't. I never have an answer for this, because at this moment, there's no clear legislation that I'm aware of, that forbids the practice of remote operations in any country. There are some guidelines, as I mentioned on the second point, from ACR manual and MHRA, ACR from the United States, MHRA from the UK. There are some mentions about how you should be doing remote operations, but it's not sufficient information that is there. And again, it's not regulated. It's just a guideline. And then, of course, this is something that I was not involved, but I'm aware of. There's a team behind the drafting of a worldwide remote operations safety standard, training as well, a dedicated training for that position that I mentioned to you, the MRI safety technologist. And this is on the horizon for very, very soon. When we speak about communication, what are the challenges for remote operations? So we have many of them. And the fact there are challenges doesn't mean that we didn't solve that problem, because we did. But it's still a challenge in a lot of hospitals, in a lot of setups. It depends what we are doing in each and dedicated situation. So communication between, for example, the remote operator and the local operator needs to be very well developed, tested, and needs to be worked properly. Then we have patient communication. Then we need to have a specific hierarchy communication workflow. So we need to be able to, in the case of an emergency, know exactly who to talk to action and when and how. So we need to have that kind of structure in place to make sure everything works fine. Then, of course, we need to be able to communicate with third parties. You want to call an ambulance, you want to call police, you want to call the fire department because you're scanning and there's a fire near scanner and the local technologist is busy taking the patient out. So you need to be able to help each other and communicate with each other throughout the whole procedure. And of course, safety and reliability of communication in terms of internet outages. Let's say there's a lack of internet, or the internet lags, or there's I don't know, power failure. So we need to be able to control all of these variables while you're doing remote scanning. Then, of course, as I mentioned, the staff acceptance, I think this one comes in tandem with most of the other challenges, like the lack of legislation and all of that. But this is a completely new field. It's hard to accept it. Change is always hard for everyone. You either are one of those people that you want to change all the time because it's super cool and you want to be on top of everything, or you're a little bit more conservative, and of course changing is hard. So I want to take it step by step. That's absolutely fine if you are in either way of the spectrum. I believe staff acceptance is something that will change slightly. We can see, as Julian was saying at the introduction, we can see this topic coming more and more. There's always a post every day about this. So people are getting more comfortable with it. And that's why we're doing this series, because we want people to understand what we're doing and understand why we're doing it and understand why we want to do it in a certain way. So of course, it needs time. We need time to do this, to make people accept, but we're getting there, and I believe we are on the good path to have more remote operations running everywhere. This is a big one as well, lack of information. So misinformation, I believe, is a big problem on the acceptance of or adoption of remote operations. There's a lot of bad actors, people taking advantage of other people that actually need the job quick. There's a limited understanding of actually what it is and how it works and when it's needed. And all of this, of course, hinders the adoption of the technology and makes it hard for everyone else that wants to understand to actually get it. So there's a lot of noise out there. What I ask every single one of you is to read more about it. Try to understand that if the people talking to you about remote operations actually do it, or actually know what they're talking about, because there's a lot of people out there that never done it. There's a lot of people out there that are not even involved in it. And it's kind of dangerous for the rest of the environment if you listen to those people and you try to follow what they're saying. But then actually it's not the reality. So just be very careful, as anything else on the internet, about what's being said out there. Then, of course, we have IT and cybersecurity. We need redundancy in terms of IT infrastructure. So if something fails, we need something that it's there as a backup, right? So if your energy fails, your power goes out, you need a generator that it's there. For example, this is an example. I'm not saying this is what we do at remote operations, but that's an example of things that we need to do. And then don't forget that we're using real-time communication. So I'll touch upon this as well later on. But we need a very robust network infrastructure, and we need to prepare and set up all of these things before we actually go and start a real remote operation. There's a lot of preparation before we actually start this. And then the last one, which is a challenge for a lot of people, it's to accept, is the concurrent scans. So scanning more than one patient at a time might be challenging, might be fear-inducing, might be stressful. You might think, I will never be able to do that. I don't want my manager to make me to scan 3 patients at a time. Our attention span is also shorter than it was a few years back. And a lot of radiographers are not happy to do this. So concurrent scans, I like to say that up to 2 scans, it's doable, very doable. And for those that do MRI, you understand when you plan a sequence or 2 or 3, 4 sequences and you're sitting there playing on your phone, you understand that you could be planning another patient. So that's the approach, of course. There will be breaks, there will be times where you don't want to do 2 scans, you just do 1. It's very flexible, but it's possible. When we go into the realm of doing 3, 4 scans, I'm against that. I don't think we should be doing 3. I don't think definitely that we should be doing 4. I know a person that does 4 scans at a time, but it's one of those people that are extremely focused, and it's rare to see. And when you do 2 scans as well, I never advise, for example, to do two cardiac scans. That's mental. You should be doing, for example, a left knee on one side and the brain on the other. So 2 parts of the anatomy that you can't confuse while you're scanning. So I would never do a left knee and the right knee on the other side. By the time you're planning one, you're probably confused with the other. So I don't advise to do that either. Right, so we spoke about advantages and challenges, and now I want to talk to you about the major pushbacks. And these major pushbacks come from the technologists, the radiographers' side. Okay, so one of them, it's not safe. We're going to touch upon safety once again, as I said. So everyone says it's not safe. Everyone there is against the technology or a bit afraid of it. It's not safe. Then they are afraid that we'll replace them or take their job away. And the last one is I'm going to lose patient contact. All of them are valid, okay? So why is it not safe? Why do you think is it not safe? I understand that with so many incidents happening all around in Finland, and every week we see incidents happening on normal operations, let's say normal, quote normal. Why would we feel safer when we're doing remote scanning, when we take the last line of defense away from the scanning room, right? So I believe that's the main concern in everyone's mind. So who does the scanning room supervision? How do I talk to the patient before and during the scan? How do I deal with claustrophobia? Who deals with contrast allergic reactions? Who deals with implants and cardiac arrest? And there's 100 more questions in terms of safety. So main safety concerns. They are separated in two rounds. So we have the related to the patient. So we have concerns related to communication. Can I talk to the patient? Can the patient talk to me? Can he tell me that he's not okay? That's one of the main concerns. And then, of course, emergencies. So I like to separate it in related to the patient. We have communication and emergencies, and then related to the operation itself. So safety in terms of connectivity. Am I connected? Is my network going down while I'm planning my cardiac scan? Is my internet failing when I'm giving breath hold instructions to my small bowel patient? So connectivity related to the operation itself. And then, of course, data security, GDPR, all of the HIPAA, all of those legislations that we have to be careful with data. So I'll touch upon each one of these slides right now. So main concerns in terms of communication. The problem is lack of real-time interaction. So people believe that there's no interaction between me as a remote and my patient due to the physical separation and the technological limitations. Very valid point. So small example, communication with the local staff. This is a tiny example of a platform. There's many others. So all the platforms nowadays have this kind of way of communicating to your local staff. So you can chat with them through instant messages. It feels like you WhatsApping them. There's video calls through cameras. There's audio calls. There's attention buttons where you can press the button, for example, here on the bottom left of that chat. You have that yellow warning sign. So when you click there, it will alert people. You have mobile phone, you have landline phone, you have satellite phone. So there's a myriad of options to communicate with the local member of staff. And then we have communication with the patient. This is one of the most critical aspects of it. So communication with the patient, you still have, remember, that MRI safety technologists on site, specifically trained for safety, specifically trained for emergencies, specifically trained for claustrophobia, contrast reactions, cardiac arrests, for all of those things. So that person's still there, still talking to your patient like we do on every single day, doing the safety questionnaire, positioning the patient, taking the doubts, calming him down, answer to the questions, why the machine makes so much noise, it's just how it works, right? So we have that person there. Then we still have the intercom, okay? Some platforms don't allow you to use the intercom, some of them do. So again, I'm not talking about one platform, I'm talking about remote operations in general. So we are allowed to talk to the patient nowadays already. This is a space to watch because there's technology coming in that will improve this communication, but we as remote can talk to our patients in certain remote operation setups. And then, of course, we still have cameras to see the patient inside the room, outside the room, control room. So we can control the whole pathway of the patient, even if we're sitting at home or in a hub somewhere else, rather than the hospital where we're scanning the patient. So communication with the patient, nothing really changes, to be honest, because you have still the person on site talking to them, and you at home can also talk to the patient. So emergencies. The main problem here, physical distance during emergencies, of course, and excessive reliance on local staff is the cause. So the staff there, your local staff, you have to rely on them for everything related to emergencies, right? Once you are at home, there's nothing you can do about the patient if the patient is not feeling well, besides calling someone externally if needed, if you're working in a outpatient setup, contacting the hospital if the local member of staff is dealing with the patient. So there's not much more than that you can do. So here is where thorough protocols and in the implementation phase of the remote operation comes to make a difference. So I'll talk about how later on how we set up a remote operation very succinctly. I'm not going into detail, but this is just a quick diagram that I made just to show you how we can navigate this. So you have the imaging manager, you have your MRMD, MRSC, MRSO, you have reporting radiologists, IT teams, PAC teams, on-site remote operations, you have MRST, remote operators, so you have everyone. The idea is you have a remote MRI operations committee, and this committee must meet either every day, either every week, either every month, whatever works for your institution, okay? There's no defined measure for one fits all. It's whatever fits you. It's what should work. And of course, we need proper SOPs before we start implementing this. We need internal policies, contingency plans, emergency drills, simulator trainings, clearly defined hierarchy. So who's managing who does what in certain specific emergencies or situations. And of course, we have the big problem of divided liability. Even today, Derek Richel, a friend, was talking about his presentation, and he believes, and I agree with him, that divided liability or liability in general is one of the pushbacks, right? One of the worries that people have, who's responsible for what, and if the patient collapses, who's responsible for that. So this is something that needs to be very, very clear at the implementation phase. When you're doing implementation phase with a hospital, you need to understand who's responsible for what in what situation. So as I said, we need to prepare these operations very, very well before we even start thinking about scanning one patient. I'll give you an example. I believe Alpha RT, Pete Jablonka, a friend as well, he mentioned in some presentation, and he mentioned to me in private conversations that it took them 3 years to test everything before they actually scanned the first patient. That's how hard they go on safety. That's how good they are at analyzing every single detail of every single emergency before they actually scan a patient. So kudos to Alpha RT as well, because they're really, really good at what they're doing. And this divided liability is a term coined by Canal as well. In an article that he wrote, he presented with Everything MRI twice about this. So it's all about planning, it's all about defining roles before we actually start the operation. Then we have, of course, specialized training. I'm going to show you a short clip, but I believe it's really important that we do this kind of training. You've probably seen this before. I'm going to skip a little bit just there. So MRI safety training needs to be there all the time. It will be there, but for the local technologies, it's really important that they have this kind of specialized training. As I told you before, it's something that is coming by the end of the year. This is a partner of our company, Do Reality. They do simulators for safety, for any other kind of environmental patient pathway. You can imagine, so you can simulate scans actually, and you can simulate the whole patient pathway, you can positioning, and this kind of training is really important for emergencies as well. Then, as I mentioned, courtesy of Dr. Canal as well, he used this slide in one of our events last year, MRI Safety Forum. We're going to have it again this year, so just stay tuned. I think it's 4th of November, by the way. So he mentioned that we're going to have the MRI safety technologists, the blue line there that I mentioned to you before. This member of staff will be specifically trained on patient care in general. So that's why I'm saying it's going to be really, really important what's going to happen within the next few months, because our role as radiographers, technologists, whatever you call it, where you are, it's going to be kind of bifurcated. So you're going to be either remote or local, and you can do both. You can be hybrid, but I'll touch upon that a little bit later as well. So connectivity, I'm going to skim through this a little bit quicker, but of course, we depend on stable internet network, right? And the cause is the remote nature of operations. So we're just scanning from across the room or across the country or whatever. So of course, the internet needs to be really, really reliable. Okay. So for that, we have network redundancy, as I mentioned. I gave a Portuguese example. So we have two network providers here in Portugal, Vodafone or NOS, and you can either have both of them connected at the same time, and one of them fails, the other one straight away jumps in and works, or you can have both of them working at the same time through a router, and if one of them fails, still nothing happens because the other one keeps emitting signal. So it's important to have network redundancy to make sure that you never lose your connection. This is very, very important when we're setting up, again, a remote operation. We need to be very careful with the network. There's a lot of details behind the IT infrastructure that needs to be prepared beforehand. This, of course, is also complemented sometimes by optic fiber, 4G and 5G. We never recommend to use Wi-Fi because it's less stable. We use Ethernet cables. So if you have a good optic fiber network, just connect the cable to the computer in order to scan. Never use Wi-Fi. Then, of course, we have alternative backups. You have Starlink, of course, satellite internet. You have the Eutelsat group, which is basically the Starlink of Europe. We have mobile hotspots, but these are, of course, last-minute resorts. Let's say you're in the middle of something really important. You're going to give a contrast on the liver, and you've done your timings. It's a dynamic scan. Your internet is lagging. You can use something else to make sure you at least go through that phase. So this is a really, really last case scenario. Then, of course, we monitorize all the networks. We make sure there's no peaks in signal. We can actually predict if the internet is lagging. If it's something we think is going to happen, we can communicate with the remote and the local operators to let them know. So all these operations are actually supervised remotely as well. The last concern is data security. So depending on, again, the stable internet networks and the same cause remote nature of operations, we use cryptography the same way as you speak on your WhatsApp, let's put it that way. There's others like Signal or I think MSN also, MSN Messenger, sorry. MSN is from the past now, but Messenger actually uses the same thing. So you have encryption throughout the receiver and the sender. So it's something that protects for all the communication that you do. Most of the operations that we use run within the hospital network. So it's not something that comes out to us and we're gonna deal with the data and then send it back. We are running within the hospital's network. Of course, you have more of those types of cybersecurity tools. I'm not going through all of them, but that's just a few examples. You have VPNs. We have, of course, the firewalls. Actually, firewalls are one of the things that we have challenged with, because most of these hospitals have really strict firewalls, and even the email that we send them to for them to register on our platform is blocked. So they don't even have access to the link of the platform sometimes. So again, this is all dealt with at the implementation phase. So let's focus a little bit more on safety. I'm going to give you a few examples. So Essen University in Germany, they were pioneers on remote scanning. Anton, the nice gentleman that was on the first picture at home scanning with his dog, he was actually the first radiographer to scan a patient from home. And he works at Essen, and they've been doing remote scanning for 9 years. Zero incidents were recorded so far. Then we have Acumen, also a North American medical services provider. They've been doing remote operations for several years as well. No safety or quality incidents have been reported. We have Ionic Health. According to their website, more than 1.5K scanners controlled remotely in South America, Europe, North America, and also no incidents have been recorded since their inception a few years back. And of course, Alpha-RT, which I mentioned already. So I'm just going to move forward with this. Okay, so I'm going to show you a quick study case from UK, actually. In UK, I used to work in UK. I worked there for almost 13 years. And we were never very open to new technologies. It's something that I always struggled with. One of the reasons why I decided to create Everything MRI as a project as well was the fact that I couldn't put my ideas anywhere, because people are very averse to new things and to change. Not only in UK, but UK was where I was, and I felt that. So Imperial College Healthcare NHS, They ran a remote operations pilot for a whole year, and they had the following goals: reduce average scan time for cardiac scans. So they basically focus on cardiacs, just to make sure everyone understands that. So reduce the number of necessary recalls, so they're not calling patients to come back to rescan or repeat the sequence. Reduce the training time, so they wanted to train their radiographers in cardiac within less time. And increase radiographer capability, so make those radiographers doing their cardiac scans more efficient. And of course, increase the number of radiographers who are trained in cardiac MR. So they had a few, they wanted way more. So these are the results. Every single one of the points that they decided to work on were extremely successful. But I want you to notice the top right corner. So they had 0% exam recall rate. So they use this platform called ROC from Philips. As I said, completely unbiased presentation, so I will mention platforms if I have to. So they had 0% exam recall rate, so they didn't call anyone back during a whole year because they were scanning remotely. So this shows that scanning remotely doesn't mean that you screw up some kind of image quality, or you're not going to be able to deal with the patient the way you would be if you were there. Nothing actually really changes. And one of the reasons why, it's because they planned this so well that by the time they're actually starting the trial, everything went really, really according to plan. So the second point of those pushbacks was, why will it replace me? This is the second biggest fear, I believe, from everyone I've ever talked to about these clients and everything. They believe that remote operations will make their role obsolete. This is me once again in book in France. While I was scanning a pineapple, I wasn't scanning, I was the local technologist in Vienna during ECR. People that were coming, some of you probably did that, came to the GE booth and they could scan the pineapple remotely. I was just there to wave and say hi. That was my role during those days. So why will it replace me? There's this nice quote from Fei-Fei Li, the co-director of Stanford Institute for Human-Centered Artificial Intelligence. There it says that artificial intelligence is not a substitute for human intelligence. It is a tool to amplify human creativity and ingenuity. So I want to transpose this quote to remote scanning. Change artificial intelligence with remote scanning. That's exactly what's happening. Remote scanning is not a substitute for human intelligence, it's a tool to amplify what we already do. We are creative people, we can figure this out, trust me. So I'm going to show you a quick video from Manny Canal in our MRI Safety Forum from last year. Again, we're going to have this year's 4th of November. He's going to talk about exactly this, the adoption of remote scanning. Just keep an ear open for this.
From a safety point of view, if we do things properly, and we do execute this in the manner we're discussing, so many of you, as a matter of professional pride, are thinking, no, they're not doing my job for me. Of course they are. You don't even have a say in the matter anymore. Please don't get angry at me. As I said in my presentation, we have pilots that are going to be piloting. Within a few months, we will have our first regulatorily approved vehicles that humans will go on. We're not talking about Amazon delivering packages alone. Humans will get onto air taxis that will be FAA approved to be flown by a pilot sitting in an office. And if they're going to have a society like that, we're going to have a society that will remotely scan humans.
There you go. So that's exactly what I was telling you about. It's no turning back. I think we are already doing it for many years in different countries. We're doing it in Brazil, we're doing it in France, we're doing it in Poland, we're doing it in the United States, we're doing it in the UK, and soon in Portugal, we're doing it in many, many countries. It's coming. Again, it's not for everyone, it's for those who need it, okay? All right. So, radiographer's task. I'm going to show you here quickly a graph. And this graph has some percentages on it, and it's just for the purpose of the point that I'm making, okay? These percentages are not real. It's just something that I put together from conversations that I had with colleagues, my own experience, and it's just to highlight the point that I'm making. So radiographers nowadays are multitaskers, right? So we do more or less, I would say, 50% of our time scanning. Then we have admin work, we have patient safety, we have patient prep, we have others like answering emails, vetting forms, chasing protocols, do phone calls, booking patients. Some of those were booking. I was scanning and booking patients at the same time on the phone. So this is just to illustrate what a normal radiographer nowadays is doing. We're not just button pushers, we are all of this and much more. So what we want to offer with remote operations is something like this. So the MRI safety technologist, as I mentioned a few times before, will do just the patient prep, patient safety, admin, and others. So this person will focus 50% more or less, or even more. As I said, these numbers are just made up numbers, but let's say 80% of their time with the patient. We never had this. We never had someone working on MR that would spend 80% of their time dealing with the patient. So now we have a dedicated patient care position, the MRI safety technologist. So what is the MRI remote operator doing? So the MRI operator is scanning. That's why we want the MRI operator doing. 95% of the time they will be scanning. Of course, there's some admin work to be done. We need to vet the patient that we have in front of us, maybe have a second screen of the patient, which is ideal. And I always encourage everyone that does remote operations to do that, to have the remote scanner, the remote operator also doing the safety questionnaire. So there's a few things that still need to be done, but most of the time we're scanning. So that's what we're going to be doing. We're going to split our profession in these two different professions. And you can come back and say, okay, but I love to look after patients, but I also like to scan. That's fine. I'll explain to you why that's fine and why this works. So this was to make the point that I told you a little bit before. So I planned, let's say, this T2 turbospin echo axial of the brain, and now I'm preparing the T1 spin echo sagittal, and I'm gonna apply this scan. I'm gonna just click on that green button on this Siemens scanner, and I have two sequences planned, right? What am I doing during this moment, during this time? Okay, this is when I'm saying, if you are a remote operator and you have 95% of your time scanning, and this is what happened, what you do with the rest of your time? You're just looking at the scanner. This is when I say that we can do two patients. While this one is running, I can do another patient on the side. And that's why I believe scanning two patients is absolutely feasible and safe. Because most of us, I speak for myself, when I was scanning MR, when I still do scan MR, when I have everything planned and I know what I'm doing, I have a lot of experience, I just pick up my phone and check some memes. That's what we all do. So again, if you are a remote operator, you will have time to do more than just one scan. Last point was, will I lose patient contact? And I was just touching upon this point. I'll go just quickly to it. So we have different remote operation work patterns, all right? So we have the full remote operation, which is a member of staff that just works from home or from a hub, all right? You just work from home or from a hub. You never go to the hospital. You never see the patients. You just talk to the patients while you're scanning. That's a fully remote job. Then you have the on-site, the MRI safety technologist, the staff that works at the point of care, as I mentioned before. And then comes the most beautiful thing of this, the hybrid. You can do both of them. You can work 3 days a week at home, 2 days at the hospital. You can work 4 weeks at home and then 4 weeks at the hospital. It's extremely flexible. You have that's a flexibility I was telling you about before, work flexibility, because you can talk to your managers and choose what you want to do, how it works better for you. For example, I hate commuting. I'm not a very extrovert person. I like to be on my corner. I would probably be doing 3 days a week at home and maybe go 2 days, because I still like to talk to my patients. I love to care for claustrophobic patients. For example, in pediatrics, you like to spend their time there. So there's a hybrid option, okay? There's more that we can talk about this, but just to be very succinct, this is how we are looking into the work patterns. So as I said before, we're going to have a bifurcated role. So we'll have on the right the scanning, of course, in your pajamas. At this point, I'm with everything MRI t-shirt, but I'm in flip-flops and some socks on. So I'm not wearing a suit or anything like that. And then you have patient care, which is the MRI safety technologist position that I was telling you about. So this is how it's going to be. This is how it is at this point in those countries and institutions that are already running remote operations. I'm going to show you quickly because I'm already hitting an hour, and I want to give you the opportunity to ask some questions or to tell me something that I don't know about because I'm here to learn from you as well. I know there's a few people here that actually do remote scanning. They might have a different perspective. So this is the reason for these webinars, is so we can share information with each other. I want to learn from you as well. So the future of remote operations from my perspective, just going to give you one short example. This is also a video and the situation that are happening in UK. Surprisingly enough, when I was saying that they're not very open to change, here we are with two different things from UK. So this is a tiny video. I might skip through it to show you exactly what it is, but this is about the holographic technology that I mentioned before.
Imagine visiting your doctor by hologram.
Sir, good afternoon. How are you today?
I feel good, actually, in fact.
You're looking at Dr. Saad Hussein,
Okay, nice.
just not in the flesh.
I looked at your EKG, your electrocardiogram, that looks good.
He has teleported to this hospital in Lancaster from several cities over
Vital function was good, so
to meet with a patient via hologram
do you have any questions?
in 3D, real time, and life size.
So as you can see, this is some kind of technology that is already happening. And this machine is, of course, huge. But this company, for example, there's more companies doing this. They do it at portrait, like a picture portrait size, where you can have, or book size, where you can have it, imagine, encrusted on your wall at zone 3 before you get in. So you actually, as a remote operator, can talk to your patient real life in an holographic manner. You can also eventually do out of the box holograms where the body is actually out of that box, because this specific technology, of course, doesn't allow you to interact much besides just looking at the patient. You can actually get up and show yourself, show your back, for example, if you have a mole there, your doctor has to check. So it's very interactive, but eventually the hologram will get out of the box and you can see it right in front of you. And that's how I see remote operations in the future work as well. This is just one example. This is an example of a client. So he has a Canon scanner on the left. I asked this person, this radiographer, if I could share this. He allowed me to do it. So on the right side, you have a GE scanner. On the left side, you have a Canon, and he's scanning both at the same time, as you can see. So remote operation setup. I'm almost done, I promise. What we do in terms of setting up, as I said, remote operations are for those who need it, not for those who want it. That's the first point. And then, of course, we start with the pre-onboarding, the planning phase. So the idea is you visit your client, the hospital or the clinic or the outpatient center, whatever it is. You go there and you sit down and you do a risk assessment. You talk to them and you try to understand that if you actually need, as a client, if you actually need that operation. You might not need it. After this conversation, we might sit down with you. You really want it. We talk about it, and then it doesn't make financial sense to you. It doesn't make safety sense to you. So there's a lot of things that we have to put together in the same box to make sure that this makes sense to you as an operation. This is the first and foremost thing that you should have done before you even think about starting a remote operation. Sit down at the table with people that know what they're doing and talk to them. Is this feasible for me? Is this a good option? Is it not a good option? Will I be cost effective or not? So all of these things are important. Then, of course, let's say we think it is financially wise to do it. It's safe to do it. The radiographers are happy. The management is happy. Let's start a kickoff and orientation. So this phase is when we basically try to show the technology to everyone, try to see if it actually works, and we start preparing for actually do the operation. During this kickoff and orientation phase, we actually run the pilot. So when we run a pilot, you just install the technology there, and you might be running for a week or 2 or 3 or a month. Some fruits, you might be running some volunteers, probably some members of your own staff, to make sure that it works, to make sure there's no problems with connectivity, that actually the setup is fine, the workflow is okay, the SOPs actually cover all the situations that you might encounter. That's the pilot situation. When the pilot is done, then you can go to the phase of training and execution. So here is when, okay, the pilot converts to an actual operation. You start seeing your patients, you train your staff, and you start executing all of this and try to make sure the operation runs smoothly. So then we have the assessment and monitoring of the operation. So as vendors or as the companies that sell the technology, there's the need always to assess and monitor the operation to make sure everything is okay. We need feedback. We need to make sure that the operation runs smoothly, the internet is okay, you don't need more cameras, maybe you have too many cameras. So we have to keep this conversation going. As I said at the beginning, don't forget, effective and clear communication are the key for a good remote operation setup. And then, of course, we have the post-onboarding support. So we give continuous support throughout the whole time. While this hospital, clinic, outpatient institution is running the operation, they should have always support from whoever installed the platform. It's not like I'm selling you a machine, you do whatever you want, I'm out of here. No, we have to keep that support going on. And again, the most important thing here, continuous feedback loop between you and your client, you and your patient. Always, is this working? Is not working? What can I improve? I don't like this. Always communicate. So when we sell a house, the most important thing is location. That's going to drive the price. In remote operations success, the most three important things are communication. So I was going to show you a quick remote scanning workflow. I don't think I'll have time for this. It's been more than an hour, but I'll try to show you quickly what I'm working on, because we're going to use this for the next webinars. Julian, can you just let me know if you see my step-by-step?
Yeah. Probably zoom it a little bit more, maybe.
Yeah. I was just making sure you can see it. All right, so what I build here is a remote operation workflow zone by zone. So as you can see here, zone by zone responsibility, step-by-step activities. So I designed the patient pathway from zone 1, zone 2, zone 3, zone 4, and then of course you have different things and safety, emergencies and everything here. So the idea is we are going to use this throughout the next webinars. That's why it's important that you follow all the webinars, because we're going to touch upon different zones with different guests. So at the moment, for example, the next webinar will be zone 1 and zone 2. We're going to talk with Martin from Germany. He's doing remote operations for a while, but we'll touch upon that a little bit later. So the idea is we go through the patient pathway. So patient checks in, documentation, safety, risk, contact MRI, collect patient, safety screen. So you can see what I'm doing. And in each one of these boxes, we have the responsible person to do that action. So for example, if we go here to zone 3, when we are doing the MRI prep room, for example, if we're doing the cannulation, do we need contrast? We have the radiologist, the patient, the remote operator, and on-site operator to make that decision. So if we decide not to cannulate, we have a pathway. If we decide to cannulate, we have another pathway. So we're going to discuss this in more detail, I hope, with our guests on the next episodes. So let me get out of this. I hope I don't close up. Can you still see my presentation?
Yes.
Perfect. All right. So we'll touch upon this workflow later on. So these are the next webinars. So as I said, we have zone 1 and zone 2, the German way with Martin Methlau. I hope I'm not killing your name, Martin. I'm really sorry. Then we have work flexibility with Zoe Holmes. Zoe is from Australia, and she's been doing remote operations for a long time, and for her, the flexibility that it provides her is a game changer. Then we have Pete Jablonka, as I mentioned before. We're going to talk about the timeout method on zone 3. That Alpha RT uses quite often. Then we have Pioneer remote scanning, as I mentioned to you before. Anton, the first radiographer to do remote scanning from home, is with us. He's going to talk about his experience, also from Germany. Then Derek, who I mentioned as well, he has a unique view in terms of multi-vendor approaches. He knows all the platforms, all of them work. So he's a great person to actually ask as well, how can I get a job in remote operations? So he's the man. So we're going to have that talk too. And then finally, we're going to have an amazing talk with Geraldine Fernandez, and she's basically doing safety training for these techs on site, which is really, really important as well. So those are the next webinars. We're going to share The link, it's on LinkedIn, but we're going to share the links of the next webinars at the end of each one. So today I'm going to share the link for the next one, which is Martin. So you just have to take a picture of that QR code and we will go from there. Okay, so this is the Worldwide Remote Operations Group that I created on LinkedIn. We have around 1,700 people, something like that there. We have experts, we have just curious people, we have laymen, we have physicists, we have all kinds of people that just want to learn more. I created because I want to learn more, so I want to understand where the knowledge is, and if I can make sure we all learn with each other. So it's a group that is growing quite fast. I'm enjoying running it. People have been super engaging and super kind to comment sometimes there about their own experience. So I have some articles here. As I mentioned, Dr. Canal, the divided liability remote MRI scanning is one of the articles that I based some of my talk on. Of course, the first one is an article that I wrote with Anton and Marcel. Actually, they wrote most of it. I helped a little bit. So thank you very much. I hope you enjoyed this presentation, and I think Julian now will take the lead for a little bit.
Well, congratulations, Sam. You can take a break, of course. My goodness, that was a hell of a presentation.
One minute toilets. I'll be right back.
It was more like a marathon rather than a presentation. Guys, I just want to remind you, well, it was a very nice presentation. I just want to remind you quickly the dates. It will be essentially all the next Tuesdays until the 27th of May. So again, 22nd of April, so next Tuesday, we have Zone 1 and Zone 2, the German way. Then on the 29th of April, we have work flexibility with a remote operation. 6th of May, we have the timed out method. And then again, 13th of May, we got pioneering remote scanning from the past to the future. And then finally, 27th of May, we got Zone 3 and Zone 4, a multi-vendor approach. So that was pretty much everything for today, but I can see there are plenty of questions here in the chat. Oh my God, I'm not sure how we're gonna address all of this. He's coming back. There you go, there you go, there you go. He deserves a tiny little break. And thank you also for assuring us that you're still wearing the trousers despite working mainly from home. That is quite reassuring. Not all the people wear those trousers. Anyway, so where to start, Sam? We got quite a lot of questions, and probably I might try to answer myself directly to you rather than asking everyone to put the mic on, because otherwise it's going to take ages. So I'm going to try to go in order, and apologies if we are going to miss Sam. I got the first one from Alessandro. Alessandro, thank you for joining us. I know also you're part of the WhatsApp group that we have, which is quite active. And how can we deal with competition for lower prices per exam among remote operation companies? This is one of the first questions.
Yes, I believe this question is in terms of if you are a radiographer or technologist doing extra hours or those shifts that are paid.
There is actually like immediately following questions as well, still from Alessandro. Do you think that price competition can affect the quality of services?
No, I don't think so. And I'll give you a quick example. There's this amazing company in Germany, and I know they're rebranding, but they're called Medcruit. And what they're doing is they have radiographers, let's say, in Egypt, and they're scanning in Germany, right? So they are in Egypt scanning patients in Germany. And what they do is, in order to hire these radiographers that are working for them, they use this AI tech and they use these platforms, let's say ScanLab from that Matthew created. So where you can actually quantify and qualify the skills of the radiographer. So you're actually hiring high-skilled people to do that remote operation. You're not just hiring someone because they're cheaper. You hire quality over quantity. That's the main idea here as well. When I mentioned that the price of the radiographer might be reduced, is in areas where they really struggle with the lack of staff. So there's no staff to actually be doing those bank and agency roles. So basically you're going to be paying less, but you at least have someone doing your scans, which you didn't have before. So I hope that answers the question.
Perfect, thank you. Then we have Ali, who I think has expressed some concerns about roles and about liability. He said, who will do the patient questionnaire, who will confirm the patient, who will witness, and also who will be responsible in case of mistake, who will be responsible if we scan wrong patient or wrong body part. So yeah, I would say mostly liability questions.
Yeah, so all of this, as I said, the liability has, please read Dr. Canal's article on this topic, is the best source of information in terms of divided liability, as he called it. I really like that term because at the end of the day, you literally have to divide where the liability is falling according to what you're doing. So when you set up this kind of operations, there's a person that is going to be responsible for the patient care, the direct patient care. And there's a person that is going to be responsible for scanning, right? So of course, if you're doing a scan and the temperature is going super high, as the SAR levels are going through the roof, you as a radiographer have limited control when you're doing remote scanning regarding that situation. You can, of course, change parameters and all of that, but it all comes down to communication, as I said. So the person on site, the MRI safety technologist, will do the safety questionnaire, will do the planning. They will be specifically trained for that. One of the things that I didn't mention on my presentation is the fact that universities across the world, I've spoken to many universities in different countries and continents, the syllabus for MRI, for their courses on radiology and MRI, often don't have any MRI safety on it as a subject. And the ones that do, it's very minimum hours. So I'll give you an example. There's this big university in UK, one of the best, and they basically have 4 hours during their 4-year degree. They have 4 hours of safety. 4 hours of safety. So do you believe that person that comes out of their university is ready to deal with the safety of a patient on site? I don't think so. So I believe with this new role, these people will have not 4 hours, but maybe 4 months or a whole year of training just on safety. So we're going to train them really, really hard. So they're going to be the ones doing all of that side of the deal, right? And at the end of the day, whoever is, you have your own tasks, so you are responsible for your tasks. The other ones are, the people on site are responsible for their own tasks. So the liability will fall within your scope, within your role. But as I said, please, I will share the article from Dr. Canal, and also you can watch on our YouTube the last MRI Safety Forum 2024, because we have that recording where Dr. Canal explains this very well in his presentation. So just take a moment, go there. He will explain this way better than I do.
Thank you, very clear, Sam. Actually, I think there will be for sure people who actually complain they didn't have even those 4 hours. Maybe there will be quite a lot, but yeah, obviously there are always the extreme situation. So another question is, will the MRI safety technologist be the only person present during remote scanning? Will they be responsible for only one patient at a time? Question.
I'm sure I've answered that. So if you're scanning from home, you're by yourself. That's why I'm saying most of the operations are not like that. Most of the operations, you are within a hub where there's a supervisor, where there's a lead, maybe sometimes there's a radiologist on site as well. There's also working remotely. And then what was the second part, sorry, of the question?
Second question was if will they be responsible for only one patient at a time?
Yeah, most of the times is one patient. You always start with one patient. Only if you're already experienced doing remote operations, you start slowly, gradually going into scanning 2 people. Some people, as I said, scan 3 and 4. The 4th one is rare, but it happens. But ideally 2 patients.
Yeah, and then Davide, part of our Fourier crew member, he's saying if he says like in a country like Italy, for example, the safety operator could be a nurse, for example, which will be mostly involved with patient care. And he's also asking how many scans could be done at the same time, potentially with a remote scan.
So I've answered that second part, so I'm going to skip it. But in terms of other having a nurse, by the way, hi Davide, it's a pleasure to have you here. So having a nurse, it's a very friction topic, because we know nurses, doctors, radiologists, radiographers, everyone likes their own job and they should be doing their own thing. I'll give you an example. In Brazil, most of the local people are nurses, but that's because of the cultural in the country. That's because how the system is set up. That's because they need it. I advise that the person doing this should be someone at least within the radiology department. It can be a CT rad, it can be an X-ray rad. Again, the training will be about patient care. All right, so we'll have patient care training, dedicated patient care. The person that is dealing with that patient doesn't need to know what a TR is, doesn't need to know what an FOV is. It doesn't need to know why padding is important and why you need to position a patient head first or feet first, depending on the scan that you're doing. Why you shouldn't bring a patient with a pacemaker straight away into the room without checking all the details. So that's all the information these people will have. They don't need to know anything about actually scanning a patient.
Perfect. Next question. From a patient perspective, do you think for a patient will be cool knowing that a person scanning resides probably in another state or possibly another country?
So that's a question that I've been asked before as well, and I have a really good answer from a personal experience. So the way I used to work with a very good friend of mine, I don't know if he's here today, Andre, we used to work together very well without even talking to each other, almost, because we were so mechanical. So the way we used to work is, for example, Andre is preparing a patient, he puts the patient in, I double check the patient on the mic, his name and part we're scanning, and I just go and scan. That patient doesn't know that I'm another person. Either they know, they recognize the voice or something like that. Otherwise, they don't know that the person that positioned them is a different person that actually scanned them. So Andre goes and positions the patient. He gets out of the room. The scanner starts boom, 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 boom. The patient doesn't know who's scanning them. That doesn't change, right? If I'm on site, 2 radiographers, and the patient might still not know. If they want to know, I think we should be open and tell them. I think we should be always open to our patients and be transparent. Just explain what's going on. At the end of the day, we're there for them. So if they're not comfortable with some of these situations, we have to have that conversation. So I believe I'm a firm supporter that if a patient wants to know what kind of operation we're running, we should tell them. It's the same thing. You want to know if you're talking to a bot, AI bot, or if you're talking to a real person on the phone. So I think it's the same rationale there.
Yeah, I agree completely. I think transparency here is the key to answer this question. How is Isaac say, how is competency check or IQ review done on MR radiographers performing remote scanning?
So sorry to interrupt you, because I just saw that Dr. Canal is actually here, which is an absolute honor. And he just sent a text saying the ABMRS has been quite active in remote MRI scanning and will likely be making some important announcements in this regard in not too distant future. So stay tuned. Dr. Canal, I've mentioned that actually on the presentation there. ABMRS is doing outstanding work on this, and there will be news for the whole community in the upcoming months, year, I would say. Thank you very much for the comment. Sorry, Julian, to interrupt. I just saw the message.
Fantastic to have Dr. Canal here. And the question was, Isaac was saying, how is competency check or IQ review done on MRI radiographers performing remote scanning?
Yeah, I think I kind of answered that question as well with the platforms as ScanLab, for example, and we do that. Basically, we assess, for example, throughout, let's say, 50 scans, if that radiographer always position the brain in the same way, or if they're starting to deviate for some reason, so we can have that conversation with them. So we have tools to make sure that the radiographers are performing at the highest standard possible.
Perfect. And then immediately after, we got Diogo who's asking, if the internet lags, does the local MRST take over in case of contrast injection and dynamic images? That's interesting.
So I believe that's a question that Dr. Canal will for sure answer way better than I do. And he's just saying that he's going to moderate.
This is quite an interesting scenario too.
Yes, I think he's just mentioning that he's going to present and moderating in RSNA about all of this. So again, please watch and listen to what he has to say. But I believe the MRST role will have that capability. They will be trained for that. And I believe that that person will have all the capacity to deal with that situation. The remote operator in the operations that I've seen and that have been helped setting up and trained for, the remote operator role is to help with the communication to the third party, like ambulances, fire departments, police, or even actually the hospital. The local technologist will have the role to rescue the patient as soon as possible, call for blue code or call for the arrest team, and the remote scan will help as much as they can remotely with the rest of the calls and emails and all the paperwork as well.
Thank you, Sam. Another 2-3 questions, then I promise we will let you go to sleep. But I know you have also like a little baby to look after. And so Yoga was also saying, do you train on-site staff or are they responsible for it?
If we train, sorry?
Do you train on-site staff or are they responsible for it? Are they responsible for their own training?
The hospital is responsible
Yeah,
for
yeah.
So from my perspective, once again, I'm not biased and I'm saying what I know for experience and for talking to clients and other colleagues. We tend to, the providers of the platforms, let's put it that way, could it be WeScan from Siemens, The Rock from Philips, Ionic Health, GE, can be RoClub, whatever. They normally provide the training for the remote technologists, We also provide the training for the local technologists on how to use the platform, right? There's two different things. So they will be able, because the local technologist also has to use the platform to communicate with the remotes. So there's two hands of this operation. So we train them on the use of the platform, and in some situations we train them on workflows, ideally workflows. Of course, we can't train them for safety and specific SOPs or anything because of conflict of interest. That kind of training should be done by the hospital itself or by ABMRS, for example, as Dr. Canal is mentioning. So we should be sending our technologists, safety technologists, our radiographers to this kind of specific training. We have the last webinar of this session will be with Geraldine, and she does this on-site safety training for the local technologists. So we're going to touch upon this in great detail on that last webinar. I think it's beginning of June, something like that.
Perfect. Thank you for mentioning that. We got also Manuel, part of the Fourier crew, who say, first of all, thank you for your presentation. The countries which are already used for remote scanning, what have they done in terms of legislation?
Hi, Emmanuel. Great to have you here as well. So in terms of legislation, as I mentioned, the way this is happening is technology will always lead, and then legislation will always lag behind, right? So we are in that phase where we're using it before it's legislated. So these countries are just using it because there's nothing legislating against it. All right. So that's what happened with AI as well. If you think about it, we were using AI even before we had the AI Act that came out last year in Europe, for example. We were using ChatGPT way before the act came out. So normally legislation will catch up on. But at this point, for example, Brazil, France, Germany, there's no legislation against this kind of activities. So we're just running with it until they keep up.
Perfect. And I
Just
think
one more thing
we
to
are,
please.
well, so Dr. Canal comment, I think we are all done, I think.
Wonderful.
Yeah, I might have actually skipped some questions. I do apologize for that. It's just I think we're running a little bit out of time here. But yeah, is there anything you would like to add, Sam, on top of this?
Not really. Just the most important thing, as I said, two important things for me is have an open mind about what we're doing. We're not trying to hurt anyone. We're not trying to take the food out of the table of anyone. What we're doing is trying to optimize the resources that we have for everyone's sake. When I say that is radiographers, technologists, doctors, hospitals, management, CEOs, we want everyone to benefit from it. We're moving into a world that is dominated by technology, and everyone says this all the time. It's kind of a cliche, but the radiographers that are going to lose their jobs, let's put it that way, are the ones that don't want to keep up with the innovations. And that's the only reason they will probably be left behind. It's not because we don't need them. We need every single one of you. We need all the radiographers that we have available. The only thing is just be there, just learn, just try to get the information from the right people, and just try to learn as much as you can and have an open mind. That's all.
Thank you, Sam. And I think Dr. Canal gave us a fantastic assist.
Yeah,
He reminded us about the fact that this conversation we had tonight will be available on our YouTube channel. We got the recordings, which we're ready for everyone who wants to kind of like review the talk as well. So I would say probably by the end of this week, you're going to find the entire conversation in there. To not miss the second appointment, so the next session, you can register now if you want, just by scanning this QR code. We're going to speak with Martin next week. So if you want to kind of like attend that conversation as well and continue this sort of like discussion we already started today, I think registering by now, you can secure a spot, and we can see you next week.
We have around 150 people on this one register already. So yeah, normally we can keep up with 100 people. I don't think we have room for more than 100 people at a time. And we have another drawing on our slides. Awesome. So yeah, as you were saying, Julian, please people just log in, and that's it. Thank you very much, everyone, for your time. Julian, thank you so much for your help and for moderating the whole thing. I truly appreciate everything you do for us.
No problem. Thank you so much for your fantastic insights about this. Thank you. Thank you, everyone, for attending. Thank you so much.